Today I will be discussing about the developmental defects of oral and maxillofacial region. So the first is the cleft lip. So cleft lip is common congenital anomaly that is caused by defective fusion of the medial, nasal, and maxillary processes during the embryologic and development. Approximately 80% of the cases are unilateral and 20% of the cases are bilateral. So cleft palate, which results from the failure of the lateral palatal shelves to fuse, often occurs conjunction with the cleft lip, although it may develop as an isolated defect. Orofacial clearing is seen with greater frequency in a variety of specific genetic syndromes, although more often it occurs in a sporadic fashion due to a combination of environmental and genetic factors. So factors known to increase the risk of clefts are includes maternal smoking, alcohol consumption, and phenytoin usage. So the next one is bifid ovula or cleft ovula. So during embryonic formation of the hard and soft palate, the lateral palatal shelves normally fuse in the midline. This fusion begins in the anterior region of the palate and progresses posteriorly to the ovula. So, if the fusion is not totally completed, then a bifid ovula may occur, which represents the most minimal manifestation of a cleft palate. So, if there is a bifid ovula, there will be signs that it may develop into a cleft palate. So, a bifid ovula can also be associated with certain genetic conditions such as van der Waals syndrome or Loeys-Dietz syndrome, which is the hypertelorism and bifid ovula or the cleft palate. So, the next one would be the double lip. So, the double lip is not really much of a really hard genetic defect. However, it is still a genetic defect because it is an uncommon oral anomaly in which there is an excess fold of tissue along the mucosal surface. As you can see in the picture here, there is an excess fold of tissue. So yeah, it either may be congenital or develop later in life. So sometimes it is genetic, sometimes it's not. So the upper lip is affected more frequently than lower lip. So there is little chance of this uncommon anomaly that this double lip may occur. So when the lips are at rest, a double lip may not be noticeable. However, when the patient smiles, the excess tissue will become evident. Double lip occasionally may be a component of Ascher syndrome, which is characterized by the following triad: double lip, blepharoklasis, or edema or the sagging of the upper eyelid, and the non-toxic thyroid enlargement. So no treatment may be required for mild forms of lower lip. For severe examples, however, they can be managed by surgical excursion. So the next one is the commissural lip pits. So they are tiny mucosal invaginations at the corners of the mouth near the vermilion border. Such depressions have been noted in 12% to 20% of the adult population, whereas among children, the reported prevalence is only about 0.2% to 0.7%. So, although such pits are often considered to be congenital defects, their increased frequency in adult patients suggests that they usually do not appear later in life. So, the next one is the paramedian lip pits and the van der Waals syndrome. So, paramedian lip pits are rare congenital invaginations that are seen in the vermilion border of the lower lip, lateral to the midline. Such lesions are bilateral, although in some instances, a single pit may be found more centrally positioned or lateral to the midline. So, paramedian lip pits are significant because they usually associate with van der Waals syndrome, which is an autosomal dominant condition that also includes cleft lip or cleft palate. So, van der Waals syndrome, this one, is the most common form of syndromic orofacial clearing, occurring in 1 out of every 40,000 to 100,000 births. It is estimated that 2% of all cleft lip and cleft palate cases are part of the van der Waals syndrome, which is caused by the mutation of the gene that encodes interferon regulatory factor, or IRF6. So, these people may not demonstrate clenching. However, they can transmit the full syndrome to their offspring. So, in some cases, this defect may be genital. So next is the Flores granules. So, sebaceous glands are common adnexal structures on the skin where they are typically associated with hair follicles. However, sebaceous glands can also be found on mucosal surfaces, where they are known as Flores granules. In the oral activity, Flores granules are seen most frequently on the upper lip vermilion and buccal mucosa. So, although they also may appear on the retromolar and pad and tonsillar pillars, the term Flores granules is also used to describe sebaceous glands found on the genitalia. So, oral Flores granules are often regarded as ectopic structures. They are found over 80% of adults, suggesting that these glands represent anatomic variation. So, their prevalence is higher in adults than in children. So, the next one is leukodema. This one is leukodema. So, leukodema is a bilateral white opalescent appearance of the buccal mucosa that may represent a normal variation in anatomy. The white appearance is created by an increase of thickness of the surface on the epithelium. So sometimes this defect may be considered as normal. So this includes numerous cells with prominent intracellular edema. Leukodema exhibits a predilection for blacks, among whom it has been described in the 70% to 90% of adults and 50% of children. In whites, their condition is a milder presentation and may be hardly noticeable. So, leukodema appears as a diffuse, milky gray-white change in the color of the buccal mucosa, which should be bilateral and symmetric. Often, the mucosal surfaces appear somewhat folded, resulting in white streaks or wrinkles. So, the diagnosis of this certain defect may be confirmed easily by stretching and everting the cheek, in which will result in the disappearance of the opalescent white change. So, no treatment or biopsy is necessary. The next is ankylosing. Ankylosing, I'm not sure. So, it is also called the tongue tie, in which refers to a short or tight attachment of the lingual frenum to the ventral tongue, which results to a limited tongue mobility. So, those people with small tongues, or those who with very small tongues are called ankyloglotic. So, it has been reported that 2% to 16% of the neonates with the male predilection However, because the tongue is normally short at birth, then grows longer at the tip, the prevalence is much lower in adults, but more on children. So the term anterior ankyloglossa is used in examples in which attachment of the frenum extends towards the tip of the tongue. Posterior ankyloglosia, however, is often more difficult to appreciate, being caused by a short submucosal collagen fibers in the posterior midline or the floor of the mouth that prevent full tongue motion. So the next one is the lingual thyroid. So the thyroid gland originally develops at the base of the tongue in the foramen cecum area and then migrates to its normal patriarchal location during early embryologic life. However, if the embryonic gland does not undergo normal migration, then a lingual thyroid may develop at the midline of the dorsal tongue at the junction of the anterior 2/3 and the posterior 2/3. Other potential sites for ectopic thyroid tissue include the floor of the mouth, the anterior neck, and the anterior neck. So the prevalence of symptomatic or clinically evident lingual thyroid has been estimated to be at 1 at every 100,000 persons. Therefore, this defect is not really common. The next is the fissured tongue, in which, as you can see, it's fissured by the name itself. So it is a benign condition characterized by the presence of multiple grooves and fissures on the dorsal of the tongue. The cause is unknown, although genetic factors may play a role. So no treatment is necessary, although daily tongue brushing can help remove any entrapped food debris that might act as a source of irritation. So the last one is hairy tongue. Hairy tongue, as you can see, it looks weird and it's described as hairy because it is a common benign condition on the dorsal of the tongue that is characterized by the elongation and hyperkeratosis of the filiform papillae, mimicking the appearance of small hairs. So depending on the population studied, the prevalence ranges from 0.5% to 11.3%. So because the elongated papillae is usually pigmented secondary to smoking, coffee or tea consumption, or chromogenic bacteria, this condition can cause it. So this condition is often referred as a black hairy tongue. So because hairy tongue is not caused by a yeast infection or different viruses, clinicians should avoid unnecessary treatment with antifungal medications. And that would be all. Thank you.